good morning. It's such a pleasure to be here. And it's Friday, it's the last day. You've been here 5 days. I understand this is your vacation time. I admire your dedication very much. I think if I lived here, I would be too distracted by the beach. I don't know if I would be here. So today I want to talk about a few things. I know that you've had several other lectures that have dealt with hereditary cancer, and I want to continue that discussion. And can everybody hear me okay without the microphone here? Okay, tell me if you can't. Wanted to talk some again about how we distinguish hereditary cancer from sporadic cancer, particularly as we're looking at family trees. And I heard that you were drawing your family trees yesterday, so that's fantastic. What we do with genetic counseling and risk assessment and what the role of a genetic counselor is, and really to go through some case examples to get a feel for when we see a family tree, a pedigree, how we assess that pedigree and the results of any genetic testing that we do. And then at the end, I wanted to talk a little bit about how the landscape of hereditary cancer genetic testing is changing as new genetic testing technologies are coming online and as new genes are being identified. So I know you've heard this before, but I really think that this is one of the most important things I say to many of the patients that I see, which is that most cancer is not hereditary. I think when people walk into a clinic concerned about hereditary cancer, they very often are under the impression or the understanding that a lot of cancer is hereditary, and they might be very worried about their family history. And it really is just a small, although very important percentage of all cancer that has a strong hereditary component. So generally between 5 to 10% of cancers, depending on the specific cancer type. And I know you've heard too why it's important. So it's a small percentage of hereditary cancer, that's hereditary, but the importance for those patients and their families is so high that we really make it a priority to be thinking carefully about what are the best ways to find individuals and families who have hereditary cancer, because identifying that has significant implications for the patient. If we find a hereditary cancer syndrome in a patient who's being treated for cancer, it might change their short-term medical management, how their cancer is being treated right now. If they have breast cancer, for example, and we find out they're at increased risk for a second breast cancer, maybe they would do something different with their surgery. And in the long term as well, if we see a woman with ovarian cancer and find out that that's hereditary and she's at increased risk for breast cancer, and she's a long-term survivor of her ovarian cancer, that's very important for her. And then, of course, for the family. So if we identify an oncology patient who has hereditary cancer, there can be a really big ripple effect of identifying many other people in that family before cancer develops so that we can work actively at reducing their risk of cancer. So if we wanted to look at how that looks in a given family, just as an example, so this is a family that we saw, and I think you've been oriented to pedigrees a little bit before, so this is the woman who is our patient, and we colored in this quadrant here to represent that she has ovarian cancer. And she was diagnosed at 57, and now she's 64, and she's got a sister with young breast cancer, and she's got a cousin with breast cancer. And that's all adding up to look concerning that there is this hereditary breast and ovarian cancer present in the family, and she underwent genetic testing, and we found a BRCA1 mutation. And when you look at her family tree and we think about how many other people in addition to herself that can impact, so she had 4 daughters, so each of those 4 daughters has a 50% chance to have inherited this mutation. And then she's got 4 nieces as well, the children of her brothers, and they're at 25% chance to have inherited this mutation. So that's a lot of women who are in this age range of 30s to 40s, where if they are at increased risk for breast and ovarian cancer, it's very important to think about doing increased screening, maybe a little when they're a little older, thinking about prophylactic surgery. And that's a lot of potentially preventable breast and ovarian cancers in this family. So we start with our patient, but then this really expands to potentially have a very positive impact on other people in the family. So when we're trying to tell, well, who is the 5 to 10% of cancer that's hereditary and who is the 90 to 95% that's mostly sporadic, genetic testing is one of our most powerful tools. But we can't really, at this time anyway, do genetic testing on every person walking down the street, and so we have to figure out who are the best people to target genetic testing to. And that's really what we're trying to do with risk assessment, is looking at a person's personal and family history to determine who would be good candidates for what particular genetic test. And answering that question of the risk assessment of the family history, it will differ depending on what the personal history of the patient is. So we can say globally overall that about 5 to 10% of cancer is hereditary, but it actually differs from cancer type to cancer type. And so this graph is just comparing a few of the more common cancers and how much of them are hereditary. So if we look at breast cancer, it's a little over 4% of breast cancer that's strongly hereditary, the kind of one gene running in the family, increasing risk of cancer very much. Between 2 and 3% of colon and uterine cancers are hereditary. Then if we look at ovarian cancer, then it's more like 10 to 12% of ovarian cancer that's hereditary. So if we look at a cancer where there's a higher percentage of it being hereditary, maybe that person needs less family history for us to be concerned. And if we look specifically at a subtype of ovarian cancer, of high-grade serous ovarian cancer, then about 15 or even maybe as high as 20% of that type of ovarian cancer is hereditary. So again, there, knowing that patient's personal history may be enough to decide that genetic testing makes sense for that patient if they're interested in it. Whereas for another type of cancer with a lower percentage being hereditary, it might be more important to look at the family history to help decide if genetic testing makes sense. And the picture can be a little more complicated for some of the more common cancers, and particularly breast cancer and colon cancer as well. It's not as purely black and white as hereditary and not hereditary. So for breast cancer, we can say that there is that about 5 to 10% that's hereditary, and then a good percentage of breast cancer that we consider mostly sporadic. But then there's a middle category that I don't think it has a great name, but we tend to call it familial breast cancer, meaning there's something going on in that family. It doesn't look like the classic hereditary cancer patterns of one gene running in the family increasing risk of cancer very much, but yet there's more breast cancer in that family than you would expect just by chance. We don't understand completely. There's a lot of research going on, and we're starting to understand, I think, what that familial breast cancer is, but that's not really what we can define very well with genetic testing at this time. But we can see it in a family history. We can see from a family tree that statistically there shouldn't be that much breast cancer in a family just by chance. There must be something going on increasing risk of cancer, and based on that family history can make screening recommendations for people in that family. When we're thinking about risk assessment, when we're looking at a given family history and wondering, is this caused due to a hereditary predisposition, we take a step back and ask, well, what are the general risk factors for cancer? So one of the biggest ones, of course, is age. So the older a person is, the higher their chance to have cancer, mainly for sporadic reasons. And so it's very important when we're looking at a family history that we think about age at diagnosis. And I think that's also something that patients who come in to see me are not necessarily familiar with before we have our discussion. They may be very worried about the family history of cancer, but then it turns out that the people in the family have been diagnosed with cancer in their 70s, and that's just much less likely to be something hereditary, and we can often be very reassuring at that point. There are environmental and lifestyle risk factors for cancer, and when we're assessing a family history, we'll think about what are the known risk factors for that type of cancer, and do people in the family have those risk factors. So some examples would be that body mass index, or BMI, is this very significant risk factor for uterine or endometrial cancer. And there's links between colon cancer and diet as well. There are some cancers that the risk is increased by significant alcohol exposure. There are a lot of cancers that the risk is increased by tobacco exposure, and it's not just lung cancer. There are many other cancers as well where the risk is increased. So sometimes what appears to be cancer running in a family might be a shared environmental exposure or lifestyle factor. So that's something that we assess as well in taking that family history. Environmental exposures, some are very clear, like we know that having a history of sunburns increases risk of melanoma. It's something that people often ask about, and there are many situations where it's not terribly clear whether and to what extent there are environmental exposures that contribute to a certain type of cancer. Sometimes there are occupational exposures, and those can also sometimes be shared in a family and look hereditary when it's not. And a classic example is mesothelioma, a particular type of lung cancer, and exposure to asbestos, which of course there's been great steps taken since that was discovered to minimize very much people's exposure. But looking back in people's family histories, sometimes we'll hear, well, Uncle so-and-so had mesothelioma, but he worked in this factory and it turned out that there was this exposure going on. For some types of cancer, there are pathogens that increase risk. So there's the link between HPV and cervix cancer. So of course, that's not going to be something hereditary because we have this other explanation. There's the H. pylori bacteria increasing risk of stomach cancer. Hepatitis B can increase risk of liver cancer. So again, when we see certain types of cancer in the family, then we might ask if there are known pathogens in those individuals. Sometimes hormones or medications can increase risk of cancer. So we know that women who are taking tamoxifen for either breast cancer prevention or for breast cancer treatment, that is a very important thing for them to be doing, but we have to acknowledge that there's a risk there too, and it does increase the risk of uterine cancer. And another example is DES, and this is actually a medication that is no longer given, but was given to pregnant women, and it was found that their daughters had an increased risk of a certain type of vaginal cancer. Other things that we think about as cancer risk factors then start to get more to the hereditary side, so ethnic background, particularly Eastern European Jewish ancestry and BRCA mutations. There's also different background prevalences of different cancers depending on ethnicity. And then family history is an important risk factor that we're going to be talking more about, and in particularly hereditary cancer syndromes. So if the characteristics of sporadic cancer in a family history, so something I often tell people is that it would be very unusual to not have a family history of cancer, because cancer is a very common condition. And if we all live to be in our 80s, then about 40% of us will develop some type of cancer, and most of that is sporadic cancer. So it's very normal for there to be cancer in somebody's family history, and that does not mean that it's hereditary. Particularly if those cancers are happening at typical ages of onset or age at diagnosis for that cancer, and it can differ from cancer to cancer what that is. But generally, for many common cancers, if we're seeing it under the age of 50, that's unusually young, and more like in the 60s and 70s is more of a typical age. Having more than one case of cancer in the family, even on the same side, does not necessarily mean it's hereditary. If we're not seeing a particular inheritance pattern or not seeing cancers that can be related to each other, or if there's some other explanation like shared environmental or occupational or lifestyle exposures. And in those cases where there is that family history, yes, that person has a family history of cancer, but likely their risk of cancer is not significantly increased based on that family history. And usually genetic testing is not going to help us there. So if that's our assessment of the family history, then we can really reassure the patient in many cases and not need to do any expensive genetic testing. And that's time well spent. Like, I never feel like that was, if someone comes to see me and I end up telling them they don't have hereditary cancer, I think that's a wonderful thing, and it's actually usually very reassuring for that patient. If they came to see us with that question, it's something that's been on their mind, and we can kind of lay out why we're not concerned about that, can really be very reassuring for them. And then there's this gray area for common cancers like breast and colon cancer, of familial cancer. Again, we're seeing maybe more cases of that type of cancer than we would expect just by chance in the family history, but it's not looking like that dominant inheritance pattern with a very greatly increased risk. Maybe the ages of onset aren't terribly young. Maybe they're variable. Sporadic cancers are common, and so it could just be random chance. You could have two relatives with breast cancer. Breast cancer is common enough that could just be random chance, but there certainly are other potential explanations as well. Maybe more subtle genetic factors that we're still understanding. Maybe there are environmental and lifestyle factors that we're still getting a handle on. But this would not look like that kind of classic hereditary cancer. And we can't always tell by looking at a family history. We don't have a perfect tool to tell us, well, that looks like familial cancer and that looks like hereditary cancer. And often what will help us to make that distinction as best we can is to do genetic testing. But if the family history didn't look very strong, then we have to be sure to understand ourselves and to share with the patients that it's unlikely we're going to find something with genetic testing, but we don't want to miss something that we could have found. If we do the genetic testing and it's negative, we still want to pay attention to that family history and still want to make recommendations for family members to do screening based on that family history. And we'll look at an example of that in a little bit. And so the classic red flags for hereditary cancer, that 5 to 10% autosomal dominant, high penetrant genes, early age of onset, often going to be under 50. Multiple primary tumors, so a woman with bilateral breast cancer, or a colon cancer patient who has 2 separate colon cancers, or a woman who has breast and ovarian cancer. Those are some of the examples. Autosomal dominant, meaning transmission from parent to child, not skipping generations. And combinations of cancers that we know go together. So we know if you have a BRCA1 or a BRCA2 mutation, you're at increased risk of breast and ovarian cancer. So if we see those 2 cancers together on the same side of the family, then we're concerned. We know that someone with Lynch syndrome is at increased risk for both colon and uterine cancer. So if we see those together in a family history, that would be concerning. And a lack of environmental risk factors. There aren't other explanations for why that cancer keeps happening in the family. And we know, particularly for hereditary breast and ovarian cancer, being of Eastern European Jewish ancestry, there's a higher background prevalence of the mutation. So we're always asking about ancestry when we see patients and really asking them to go back as far as they can in knowing countries of origin, where in the world their genes came from, which is a complicated question. And so we never have perfect information on that, I don't think, but we work with what we have. And then there are certain cancer types that are more likely to be hereditary than other types. One of those is pretty rare, but very highly likely to be hereditary, and that's a certain type of thyroid cancer called medullary thyroid cancer. The more common types of thyroid cancer are very rarely hereditary, but particularly medullary thyroid cancer can often be associated with a multiple endocrine neoplasia syndrome. And so at MD Anderson, anybody who has medullary thyroid cancer is offered genetic testing, and many other places as well, for that particular condition. Pheochromocytomas, or tumors of the adrenal gland, have also a particularly high incidence of being hereditary, and there are multiple different syndromes and genes that can cause a hereditary predisposition to pheochromocytoma. Again, we really recommend that all of our pheochromocytoma patients be referred to have their family history assessed to see what hereditary cancer syndromes may be most likely. And I mentioned before this particular type of ovarian cancer, and that's something that I work directly with, the high-grade serous ovarian cancer, that about at least 15, somewhere in the range of 15 to 20% of this type of ovarian cancer is due to BRCA1 and BRCA2 mutations, and that's a very high rate. And so we're in the process of implementing procedures in our gynecologic oncology clinic to ensure as best we can that every single high-grade serous ovarian cancer patient who walks in the door is offered the opportunity to have BRCA1 and BRCA2 genetic testing if they wish to, regardless of their family history. So what is risk assessment and genetic counseling? I've been talking with several people about genetic counseling and Puerto Rico, and learning that there are not cancer genetic counselors working in Puerto Rico, so I thought I might start by talking about what genetic counselors do. So just a general definition of what genetic counselors do, and this would apply across the board. There are genetic counselors working in a lot of different settings, including hereditary cancer. There are also a lot of genetic counselors who work in a prenatal setting with couples whose pregnancies are at risk for genetic conditions for a variety of reasons. Genetic counselors also work with medical geneticists in pediatric clinics with children who have diagnosed genetic disorders. And we work as members of healthcare teams and in a variety of settings, and primary responsibilities for a genetic counselor are to provide expertise in clinical genetics, to counsel and communicate with patients on matters of clinical genetics, and to provide genetic counseling services in accordance with professional ethics and values. So the way that we become genetic counselors is there's a specialized master's degree program, and then there's a certification exam as well. There are 31 accredited genetic counseling training programs in the United States, and there are more than 2,400 certified genetic counselors, and there are more than 600 of them who actually specialize in hereditary cancer. And I thought you might want to hear too about kind of how I came to be a genetic counselor. So I started as an undergraduate in biology, and actually with particular interest in genetics. I started out actually moving in the direction of a research career, and spent a lot of time in the research lab, and found that that just was not quite the right fit for me, that I enjoyed the genetics very much, but was missing the opportunity to interact with patients. And that led me eventually to look at genetic counseling as actually a nice way to bring those things together, and have been working as a genetic counselor for 10 years since then. So what we do when we see a patient in general, and this kind of applies a lot of it across the board, whether it's in a cancer setting or in a different setting, we do contracting. And what we mean by that is having a discussion with the patient up front about what the purpose of the consultation is, and also to find out what their expectations are. They've probably never met with somebody to talk about genetics before. May themselves have never heard of a genetic counselor before, so we kind of set an agenda in the beginning, figure out what the goals are for that consultation, make sure that they're going to be met, and that the patient understands what our goals are as well. We spend a lot of time gathering that family history information, and then looking at that family history information for risk assessment, providing counseling before doing a genetic test to really facilitate that patient's decision making. We may be recommending a genetic test for very good and valid reasons, but they are very personal decisions, and different patients would make different decisions about whether they want to have that genetic test done. So we want to make sure that we provided them with enough information so that they can make an informed decision about a genetic test and whatever their decision ends up being. And then once we have the results back, to help interpret those results in the context, in this case, of their personal and family history of cancer. And then also, when we found something with the genetic testing, to really promote discussion of that with their at-risk relatives. Again, that's where a lot of the benefit of hereditary cancer genetic testing comes from. So we want to make sure that we facilitate that process as best we can, and provide the patient with tools for having that discussion with family members. That is not always, or probably never, an easy discussion to have with relatives. So you spent some time on this yesterday, which is wonderful, so I don't need to spend time on this here. So this is just kind of showing us what a pedigree looks like, and who the people are and how they're connected to each other. The circles, just to review, are women, and the squares are men. Any particular generation will be on a horizontal line. So we have, the patient here, and then their brothers and sisters all on that same horizontal line. And then the vertical lines will move us to a different generation, so down to children and up to parents, and then up again to grandparents. And there's a lot of information that you just get from having this visual representation of a family tree that you just don't get from sort of listing out somebody's family history. You get to see really visually how the people who've had cancer are related to each other. Are there relatives in between them who have not had cancer, who have had cancer, or died at a young age, or didn't, or lived to be 95? That's all going to impact the risk assessment. And it's really very helpful for the patient as well. Sometimes you list a family history and it looks very worrisome to be hereditary because it's a long list. But then if you draw out a family tree and discover that it's a huge family, and the people who have cancer are on different sides of the family and they're not closely related to each other, then you see really more of a complete picture from having that pedigree, that family tree. That process, the genetic counseling overall, thinking about hereditary cancer and particularly asking about family history, can bring up some challenging psychosocial issues for patients. They can be in a difficult place themselves. We're often seeing people who were newly diagnosed with cancer. That's what brought them to the clinic, and now additionally this question of hereditary cancer is coming up. Talking about family history can bring up difficult memories for people. Sometimes people have misconceptions about their family history. Maybe there's sort of family stories or family lore. They may not know exactly what type of cancer people in the family have had. I often hear in older generations that people are just very reluctant to talk about health problems, and particularly like female cancers. That those are just things that often in families people did not feel comfortable talking about, and so there may be information that we just don't have access to. And so when we're thinking about risk assessment, we think too about what don't we know about this family history for whatever reasons those are. And we also, again, are thinking about, well, are there other environmental or lifestyle factors that could have impacted the risk of cancer? That can be a delicate discussion. We certainly don't want to have a patient feel like we're trying to blame them for their cancer in any way. That's absolutely not what we're trying to do. We're just trying to assess what are the risk factors that could have been in play. I always reassure patients that there's never a cancer that was caused by one thing. Every cancer has multiple causes, some of which we understand and some of which we don't. So in gathering that family history, it really enables us to accurately perform a risk assessment regarding hereditary cancer, identify other cancer risks for that patient, for relatives, and recommend appropriate management. And also it can help us in the interpretation of genetic test results to have that family history background. It's not always entirely straightforward interpreting genetic test results, and the family history can very much help with that. So when we're recording a family history for everyone in the family, we want to know their gender, of course. There are cancers whose risk is specific to gender. If they're living, we want to know their age. If they're deceased, the age at which they passed away and their cause of death if known. We want to know about relevant medical problems. That can be a little bit tricky sometimes. Some patients are storytellers, and if we start asking about family history and we start hearing about every single medical problem that everyone in the family ever had, that's going to be a really, really, really long visit, and not all of that information is relevant. So we try to tailor our questions about medical problems to things that could impact risk of cancer. And we think about prophylactic surgery too. So when we're thinking about hereditary cancer, we think about it being something that doesn't skip generations. But if we're worried about hereditary breast and ovarian cancer coming from your mother's side of the family, and your mother had a hysterectomy, had her ovaries removed at a young age for some other reason, then that removed her risk of ovarian cancer. So we have to think about, well, what cancers were people still at risk for, or had they had the organs for that cancer removed for some reason, had they had a prophylactic surgery. Anyone who's had cancer, we want to know the type, and as specific as possible. And sometimes we get good specific information, and sometimes we get Uncle so-and-so had cancer and we don't know what type it was. We want to know the age at diagnosis, and it doesn't have to be exact. I don't care if it was 62 or 63, but I care whether it was in the 60s versus in the 30s. Are there people in the family who've had more than one cancer? And that, again, for patients coming in who don't have a background in oncology, helping them to distinguish between a cancer that then metastasized somewhere else in the body versus one of their relatives truly having two separate cancers. We try to ask some specific questions to tell the difference between those, and asking about lifestyle factors that could impact cancer risk. Sometimes in collecting the family history, if there's missing information, we're not sure whether Aunt so-and-so had ovarian cancer or uterine cancer or cervix cancer, and it would make a really big difference to the risk assessment to know whether she had ovarian cancer versus uterine cancer versus cervix cancer. We might try to get actually confirmation of that diagnosis, which would be through requesting medical records. So that can be a bit laborious, but sometimes it's important to the risk assessment, so we'll try to work with the family to actually get pathology reports on cancers when it's going to make a significant impact to our understanding of their family history. Sometimes there's non-malignant findings that can be associated with hereditary cancer syndrome, so we want to try to ask about those as well. Colon polyps would be one example. Certain hereditary cancer syndromes have some characteristic skin lumps and bumps that we might be asking about or thinking about. And then we extend the pedigree around cancer diagnoses. And what I mean by that is I don't necessarily ask somebody about every single one of their first cousins, if they have lots and lots of first cousins. But if they had an aunt, for example, who had breast cancer, then I'm going to ask about every single one of her children and exactly what their ages are, and if they've ever had cancer, and as much information as I can get. So we'll kind of track the family tree in whatever direction looks like to be very important. And any cancer diagnosis in the family, we want to ask very specifically about the close relatives of that person who's had cancer. And we want to make sure not to forget to get all of the unaffected relatives, because in assessing the risk, one of the questions we're asking is how many people in the family have had cancer and how many of the people in the family have not had cancer. So if you have 2 aunts and both of them have had breast cancer, that looks very concerning. If you have 12 aunts and 2 of them have had breast cancer, that's probably less concerning to be hereditary. So thinking specifically about risk assessment, what is it? So this is a general definition of risk assessment. The qualitative or quantitative estimation of the likelihood of adverse effects that may result from exposure to specified health hazards or from the absence of beneficial influences. Whew. Well, that's maybe not so helpful. So risk assessment in this context, what we are thinking about in looking at a family history. So I'm asking myself a question. Given my patient's cancer history, my patient's family history, and what I know about these particular cancers, what's their average age of onset, what's their incidence in the general population, how frequently are they hereditary? How concerning are all these factors, once evaluated together, for that patient and family to have a hereditary cancer syndrome? And if so, what cancer syndromes and genes would be in my differential diagnosis? What would be the most likely gene or genes to be responsible for this pattern of cancer in the family? So that's more specifically the risk assessment in the hereditary cancer realm. So we do this, it's partly for the patient's benefit to really educate them about their chance of developing cancer, and it's really a mutual exchange of information as we're going through this process, helping them to derive personal meaning from that information and empowering them to make educated decisions. Their decisions about genetic testing may in part hinge on the likelihood of there being hereditary cancer in the family, and to provide them with more accurate cancer risk information. There's a lot of ways to describe risk, and different people respond differently to different descriptions of risk. If you think about any given risk and all the different ways that you could express it, what will make more sense to any given patient might depend on a lot of things, including their educational background. Percentages are a great way to report risks. It's not always the best way to report a risk to a patient. It's certainly information we usually provide, but that we think about, are there other ways to provide this information in a context that might provide more helpful information to the patient? More sort of qualitative risk assessments, like a likelihood, there's a low chance for this to be hereditary, there's a high chance for it to be hereditary. Relative risk would be comparing something to general population risk, and so that can provide kind of a benchmark for understanding that risk. Proportions can be helpful because it's really visual, like a 1 in 10 chance of something, then you can imagine, 10 balls and one of them is black and the other 9 are white, and what's the chances that you'll get the black one? But they can be hard to compare to each other. So how do you compare 1 in 10 to 1 in 7? And particularly people who don't have a lot of formal education, that can be very challenging to compare risks like that, where the denominator is what's changing. So that can be more or less helpful in different circumstances. We often give ranges because we don't necessarily have such precise information about risk assessment. You have a 4.5% chance to have hereditary cancer. It's really usually going to be more of a range. And we try to use analogies a lot. So coin flipping is a great analogy when we're talking about heredity. So if you have a BRCA mutation, there's a 50-50 chance for each child to inherit it. And it might seem so obvious, that 50-50, but it's really not to a lot of patients a lot of the time. And part of what we are helping people to understand is that there's an independent risk for each child, and the coin flipping can be really helpful with that. and even people who have a strong educational background, it's different when they're thinking about themselves and thinking about their children. And so a reminder never hurts. So you can have 4 children, and if you have a BRCA mutation, it could be that none of them test positive. It could be that all of them test positive. It's not that 2 are going to be positive and 2 are going to be negative, because you can flip 4 heads in a row if you're flipping a coin, and you can flip 4 tails in a row if you're flipping a coin. And comparing risk to something else as well. Higher than average, very similar to average, can be helpful also. So when we're looking at a family history, some of the questions we ask ourselves, so we've spent a lot of time asking the patient questions, and now we're going to look at this information that we've gathered in the pedigree and start asking ourselves some questions. So how common is any given cancer? I'm seeing that family history in the general population. If I see a rare cancer, of course, happening multiple times in a family, then that almost has to be hereditary, as opposed to a common cancer can happen in a family history more than once, maybe just by chance. What are the known risk factors for that cancer in the general population? Does the patient have those risk factors? What's the average age of onset in the general population? What's the average age of onset for that cancer when it's hereditary, and how does that compare to what I'm seeing in the family history? And how old was my patient diagnosed when compared to the general population? And in the end, in risk assessment, what we're really thinking about and trying to come up with is, what is this pedigree telling me? What story is it telling me? Does this look like hereditary cancer? Does it look like sporadic cancer? Does it look like something in between? And then what are we doing with that? Are we offering genetic testing to the patient for what genes? Who in the family would be the best person to have that test? It's not always the person who came to see us. And what's going to change? And this is always an important question to ask when we're thinking about genetic testing. What is going to be different for this family if we find something with this genetic test? So I wanted to go through some cases and just sort of talk about the process of assessing their family histories and what the genetic test results were and how we got there. So here's an example of a very young woman, a 28-year-old woman who at age 27 was diagnosed with what we call triple negative breast cancer, meaning that it's negative for estrogen receptor, progesterone receptor, and HER2/neu. So the cancer is not expressing any of those. And that's commonly referred to as a triple negative breast cancer. And we've come to understand that that triple negative type of breast cancer has a high likelihood to be due to a BRCA1 mutation. She doesn't have a significant family history of cancer. Her mother is 50. Her maternal grandmother, we don't have her age, but she's not had cancer. There's a mouth cancer in somebody who died at 70. That's probably not something hereditary. Her father is 60. She's got 2 paternal aunts who don't have cancer. Her paternal grandmother is 95 and doesn't have cancer. So what do we think? What is this pedigree telling us? Well, there isn't a relevant family history. There's no family history of breast cancer. There's no family history of ovarian cancer. But she was very young at diagnosis, and she has a triple negative histology of her breast cancer, and that is all concerning for hereditary cancer, even though there's not a family history, and specifically concerning for BRCA, specifically BRCA1, but we always do the genetic test of both together. It's not the only gene that we would think about in this family. When someone was diagnosed with breast cancer very young, like under the age of 30, there's another more rare hereditary cancer syndrome caused by germline mutations in the P53 gene that is called Li-Fraumeni syndrome, and I don't know if that's been mentioned in any of the talks that you've had. So when a breast cancer is young enough, even though we're not seeing the other Li-Fraumeni syndrome cancers in the family, like sarcomas and brain tumors and those kinds of things, we would still consider that. We'd probably usually do the BRCA testing first, but then if that's negative, then P53 would be, for this family where she was diagnosed so young, would be a very reasonable consideration. So for BRCA, it's extraordinarily rare, we believe, to have a de novo mutation, but it's probably less rare for P53, and we're actually going to come back to that in the later in the talk. There is probably a higher de novo rate for P53 mutations, so meaning that you're the first person in the family to have that hereditary cancer syndrome, which is a potential explanation for why there wouldn't be a family history. The new mutation rate for BRCA1 and BRCA2 seems to be extremely low. So almost always when we find a BRCA mutation, it is coming from one of the parents. It's very interesting. There's, I think, a wide range of reasons why the new mutation rate differs from syndrome to syndrome. So there are genetic conditions like neurofibromatosis where 50% of people who have that condition are the first person in the family to have it. It's a de novo mutation. It happened either when they were a zygote or in the egg or sperm, so there's no family history of it. And then other conditions like BRCA are almost never a new mutation. Very interesting. So in this particular case, the patient did have a BRCA1 mutation, so we ended up not doing P53 genetic testing, but we would have if the BRCA testing had been negative. So knowing then that the new mutation rate is very low for BRCA, why isn't there any family history? What do you think? Why doesn't she have a family history of breast and ovarian cancer?
Maybe her father.
Yeah, could be coming. Now her father has 2 sisters. But absolutely, it's not unsurprising for a man with a BRCA mutation to not have cancer. They can develop breast cancer and their risk is higher than the average man, but it's still not very high. And we don't know honestly what the reason is, but it could be that she inherited it from her dad. It could be that these 2 aunts happen to have not inherited it. Maybe it came from the grandfather. It probably didn't come from the 95-year-old paternal grandmother who doesn't have cancer, but it's possible. So the cancer risk for these syndromes is almost never 100%, and for BRCA it certainly isn't 100%. So you can be 95 and have a BRCA mutation and not have cancer. It's just not very common, but it does happen, and we actually have patients like that. We've identified people at least up into their 70s who, by tracing, just like this, tracing the BRCA mutation in the family, we end up finding out that you are a 75-year-old woman who has a BRCA1 mutation and has never had cancer. So that's certainly a possibility. A lot of people in this family are young. So she's really young, and that means the generation above her is pretty young as well. So while her mother's never had cancer, her mother is 50. So if we had looked at this pedigree 10 years from now, who knows if it might have looked different. So we think too about how old are the at-risk relatives. And so the family history here didn't really help us make a decision about testing. If anything, it could have led us down the wrong path of saying she didn't need it because she didn't have a family history. Now that we know her genetic test results, how can this pedigree be helpful to us? Yes?
You can warn the aunts and
Yeah.
aunts and
Yeah.
so.
It helps us to figure out who in the family is or isn't at risk for this mutation. So I would very much like for her parents to have genetic testing so that, because I can't tell by looking at this family history whether she inherited it from her mother or her father. And we'd really like to know, well, this 21-year-old man, he might not care terribly right now about whether he has a BRCA mutation, but if he has daughters, he might end up caring very much about it. Do we need to tell people on this side of the family, or do we need to tell people on this side of the family? So it's very helpful, and actually I think it helps the patients as well to really have that visual representation. And we'll often write on the family tree and think about who are the people in this family who could be at risk and why would that information be important to them. So here's another case. So this is a 62-year-old man, and he has had 2 separate colon cancers. His first one was at age 38, the second one was at age 55. And he's got a lot of family history as well. His mother had colon cancer at 67 and subsequently passed away, and his father had colon cancer at 76 and subsequently passed away. There's also a paternal aunt who had colon cancer at 38. So that's a lot of colon cancer in this family. So that's very suggestive. It hits like every red flag, right, for hereditary cancer. So it doesn't take much formal training in genetics to look at that and say, you know what, colon cancer is running in that family. So what do we do next? So the first step, and I'm sure you talked about this yesterday, what we do first is to do microsatellite instability and immunohistochemical analysis of his colon cancer. And in this case, that showed loss of staining for MSH2 and MSH6, and the colon cancer showed high levels of microsatellite instability. So that pattern of results would tell us to offer that person MSH2 genetic testing. Usually when both of those proteins are lost, it's because of an MSH2 mutation. There is another gene called EpCAM that sort of sits right next to MSH2, and it was recently learned that you can have a deletion of that gene that causes MSH2 to stop working as well. So when we do MSH2 genetic testing, it now includes EpCAM genetic testing. So that's what we would recommend for this individual. And he was MSH2 positive. So we're not surprised by that, right? So once we had his tumor study results, we already were very concerned about him having Lynch syndrome or HNPCC. But with the positive genetic test results, that gives us an additional tool of being able to test his at-risk relatives. So certainly his 60-year-old brother is someone that we'd be very concerned of having this 50-50 chance to have Lynch syndrome. And such an opportunity for colon cancer prevention. He's at an age where risk of colon cancer would be quite high if he has Lynch syndrome. If he tests positive, then he's having a colonoscopy every 1 to 2 years. If his brother tests negative, then he still has to have a colonoscopy because he's 60, but he can just do it every 5 to 10 years. And this man has 2 daughters who are in their early 30s. And so if they test negative, again, we can really reassure them that you have this family history of colon cancer, but we know what's causing it and you didn't inherit it, and you do not need to do any extra colon cancer screening. You can follow the general recommendations of having a colonoscopy at 50. Whereas if either of those daughters tests positive, then we're going to start now doing that colonoscopy every 1 to 2 years, and also think about screening for endometrial cancer with endometrial biopsies, because the risk of that is elevated in Lynch syndrome as well. So what if this genetic test had come back negative? What do you think that would mean if we'd done the MSH2 genetic test and it came back normal? Well, that's the right answer, because nobody knows, really. And this actually happens more frequently than we'd like it to. So there's a lot of different possible explanations. One of them is that this gentleman does have Lynch syndrome, just like his tumor studies were telling us, and the genetic test can't find the mutation. So no genetic test is perfect. No genetic test that has 100% sensitivity. Maybe, and there's a great example of this EpCAM. Like 3 years ago, we didn't know about EpCAM and we didn't test for it, and that ended up being the explanation for some families where the genetic testing was initially negative and now there's a better genetic test and now it's positive. So maybe 3 years from now there will be a better genetic test that would provide an explanation if this genetic test didn't. So that's one possibility, is it is Lynch syndrome and we don't have a genetic test that can find the specific cause right now. Another possible explanation could be that there could be some other way that the tumor ends up looking like this, having high microsatellite instability and loss of MSH2 and MSH6. We know that that can be caused by MSH2 mutations, and we don't know of other ways that that can happen in a colon cancer, like other somatic or epigenetic causes, but that doesn't mean they're not out there. Just because we haven't found it doesn't mean it's not out there. In this family, with this strong family history of colon cancer, I would very much tend in the direction of this is Lynch syndrome and we just need our genetic test to get better. But in a different family where there's no family history, we always, if we're not sure what's going on, we always err on the side of caution. And so if the tumor studies told us it's Lynch syndrome and the genetic testing doesn't, we advise that family to assume that they have Lynch syndrome and to follow those screening recommendations. But that's not to say that we know that it's Lynch syndrome. It's that we're erring on the side of caution and that maybe we'll have something more definitive in the future. So it is really a rapidly evolving field, and things really do change, and genetic tests change, and our understanding the results change as well. So here's another case. So this is a 70-year-old woman who at 63 was diagnosed with high-grade serous ovarian cancer. So I met her 7 years after she was diagnosed with ovarian cancer. That means she's a long-term survivor of ovarian cancer. And that actually is something that also has been associated with BRCA mutations. So the survival seems to be better from high-grade serous ovarian cancer in women who have BRCA mutations than in sporadic ovarian cancers. She's got a very strong family history. She has a twin sister, that's what the kind of triangle there means, that's her twin, who was diagnosed with breast cancer at 36 and passed away at 38. And she has a daughter who had breast cancer diagnosed at 41. So again, you do not need a lot of genetics expertise to look at that and say there is a predisposition to cancer running in that family. So we didn't, again, she's got that high-grade serous ovarian cancer, that type of ovarian cancer that at least 15% of it is hereditary. So we didn't need her strong family history to tell us that she was a good candidate for BRCA1 and BRCA2 genetic testing. We knew that as soon as we knew that she had high-grade serous ovarian cancer. But knowing her family history does certainly increase the likelihood of having a mutation, and it allowed us to be able to say to her before doing the test that we feel, we never know for sure, but we feel very certain that we're going to be finding a BRCA mutation with this testing, so that she was apprised of that ahead of time, and that helped her to not be surprised by the results, which she was not. Which were BRCA1 positive. And often with a lot of the patients that we see, but particularly those with a strong family history, this can be emotionally difficult information and thinking about sharing it with relatives. However, at the same time, what we often find is before they ever met me, they have been worried about why cancer is running in their family for a long time. So again, you don't need genetics expertise to look at that family history and see that something's running in that family. The family already knew that. They knew that something was running in the family, increasing risk of cancer. So we're not surprising them with a BRCA1 positive genetic test result. And it's really, often it's more that we're confirming something that they already knew, and more importantly, providing them with a tool and an opportunity. So this family now has an opportunity, and this family in particular, a lot of people in this family have taken advantage of this opportunity to focus on prevention. So when we see women with ovarian cancer who have daughters, they're often very worried about their daughters. They do not want their daughters to go through what they went through. Treatment for ovarian cancer is not easy. And if there is something that they can do to help prevent that possibility for their daughters, overwhelmingly, at least in the people that I've met, they want to do it. One of the particular questions that this patient had is what this means for her grandchildren. So she had really been thinking about this for a long time before I saw her. And when I met her, her grandchildren were 13 and 9. So that gave us an opportunity to really talk about timing of genetic testing and informed decision making and autonomy. If it were up to our patient, I think that she would have marched the 13-year-old and the 9-year-old into the clinic the next day and had their blood drawn with the best of goodwill and good intentions. Would that be the right thing to do for a 9-year-old and a 13-year-old? I don't think so, and there's plenty of professional guidelines saying it's not the right thing as well. But she had good intentions, and so we had to start there and recognizing that she is trying to protect them. So everyone here has good intentions. We're not saying that anyone's got a bad idea or has bad intentions. But we were able to talk through, what this family history had been like for those girls, what their maturity level is, how important it is for right now for them to be focusing on being a 9-year-old girl and a 13-year-old girl and going through school and doing what kids that age are supposed to do, as opposed to thinking about being at increased risk for cancer. Now, at the same time, they know this family history too. This is a very open family, and so it is on their minds. And we also talked about, well, at what age would we start doing something different for those girls? And it's not at this age. There is no increased risk of cancer with a BRCA mutation before the age of 25, and even then the risk is low. But that's about when we start doing breast cancer screening, generally is around the age of 25 if we know a woman is BRCA positive. So what we ended up doing actually here is I met with those girls not to talk about genetic testing, not to offer them genetic testing, but to help them understand, with the family's help, what this family history of cancer means and what might be possibilities for them moving forward, and also to reassure them that there is nothing that they need to be worrying about right now. So it ended up being really a valuable interaction with this family that started with a kind of a, ooh, you want your 13-year-old granddaughter tested for a BRCA mutation and we don't think that's a good idea, but then grew into a really fruitful discussion in a family that we've really been able to stay in touch with over time. Okay, so switching to a different case. So this is a 49-year-old woman who was diagnosed with endometrial cancer at the age of 47. Her BMI is 24, which is a normal BMI, and I point that out because this is one of those cases where there is an environmental exposure of BMI, a personal medical history factor that has a very strong role in endometrial cancer. So women who have a BMI over 30 are at greatly increased risk of endometrial cancer compared to the general population. So when we're thinking about whether it's hereditary or not, the absence of that risk factor makes me more concerned that it's hereditary. She's young and she doesn't have obvious risk factors for endometrial cancer in her personal history. Her family history is not overwhelming. She has an uncle who was diagnosed with colon cancer at 70. That's a pretty typical age to get colon cancer just by chance. So what do we do? So again, she does not have typical endometrial cancer risk factors, and she was diagnosed at a young age, but her family history is not very concerning. So this could go either way, right? I don't know before doing testing what way this is going to go. But we generally want to kind of cast a wide net because we know that family history is not a perfect tool. And we did MSI and IHC analysis of her endometrial cancer. And the IHC showed loss of MSH6 only, and the endometrial cancer is MSI high. So that's a pattern that's very indicative of an MSH6 mutation, so Lynch syndrome caused by MSH6, and that is in fact what happened. She tested positive for an MSH6 mutation. And there's these 4 genes, MLH1, MSH2, MSH6, and PMS2. We call them all Lynch syndrome. We lump them all together, but there are differences between those genes. There are even differences between BRCA1 and BRCA2, but I think even more pronounced in Lynch syndrome, where most Lynch syndrome and most of the studies that have been done on Lynch syndrome have been done in people who have MLH1 and MSH2 mutations, and they have higher risks of colon and uterine cancer. And women with MSA, or people with MSH6 mutations and also PMS2 mutations, they do have an increased risk of cancer, and we do call it Lynch syndrome, but the risks are not as high as with MLH1 and MSH2. So now knowing that, it kind of makes sense that she didn't have so much in the way of family history. The risk of colon cancer with MSH6 mutations is elevated over the general population, but it's not as high as it is with an MLH1 or an MSH2 mutation. Remember what this family history looked like with the MSH2 mutation. They look very different. Now, we'll see variability even within a particular gene. I could see a family that looks just like this and has an MSH2 mutation as well. That happens. But that lack of a strong family history is consistent with the MSH6 mutation. So here's another case. This is a 40-year-old man who has a sigmoid colon cancer, recently diagnosed, and not so much in the way of family history. So he's got some cancer in the family, but it looks like those kind of sporadic cancers that just happen by chance. So leukemia in someone in her 80s and prostate cancer at 80. Prostate cancer is so common in men over the age of 70 in particular. There has to be a very strong family history before we'd be concerned about that. We did a little abbreviating. So here's 3 paternal aunts who are all in their 50s to 60s with no history of cancer. But he's young. He's young to have colon cancer. So we're doing pretty universal tumor testing, MSI and IHC testing for colon cancers, because sometimes this person ends up having Lynch syndrome. Maybe it's the more subtle MSH6 or PMS2, or maybe there's just missing information about the family history, or for no reason at all, and just that the cancer risks are not 100%. So we did tumor studies here, and they were normal. So the IHC showed normal staining for MLH1, MSH2, MSH6, and PMS2, and it's a microsatellite stable tumor. So we don't need to do any genetic testing. So the tumor studies were normal and the family history was reassuring, so we can stop right there. But we still pay attention to the family history and think about what that means for relatives. There's still a risk assessment to be done. So he's got a 42-year-old brother, and this is a man who was diagnosed with colon cancer at 40. Maybe this is something in that familial colon cancer. We don't completely understand it, but something's increasing risk of cancer in the family, kind of a thing. So we do, at that point, more of an empiric risk assessment. We don't have a genetic test result to tell us what people's risk of cancer is, but the family history is an important tool as well. And so the guidelines, if you have a first-degree relative who was diagnosed with colon cancer under 50, so first-degree relative would be a parent, a child, or a sibling. So if you have a parent, a sibling, or a child who's had colon cancer under 50, then the recommendation is to begin screening colonoscopy, not at 50 like the general population, but to begin that either at 40 or 10 years younger than the youngest diagnosis, whichever comes first. And so in this family, what this means is that the 42-year-old brother needs to go have a colonoscopy now if he hasn't already done it. And you'd be surprised how often they haven't already done that. And then these children, nothing they need to do now, but they should have their first screening colonoscopy when they're 30. And this is a similar but a little bit different case where we have a 51-year-old woman who was diagnosed with colon cancer at 50 and does have some family history. So her father was also diagnosed relatively young with colon cancer. And then on the other side of the family, there's a maternal grandmother with colon cancer in her 70s. And often, this is another case where drawing out the family history really helps us in helping the patient to understand that you don't add the colon cancer on dad's side of the family to the colon cancer on mom's side of the family. It's two separate families. You've got genes coming from this side, you've got genes coming from that side. Because I think in the patient's mind, she's got all these relatives with colon cancer, and it turns out they're on different sides of the family, and this is just a good visual way to help the patient understand that. Of course, given that family history, we would do tumor studies, and they came out normal in this case as well. So this really looks like some kind of familial clustering of colon cancer not being caused by Lynch syndrome. There's not a role for genetic testing here, but we do need to counsel them that they need to pay attention to that family history. We don't want this person walking out thinking there's no increased risk of colon cancer in this family because the tumor studies came out normal. We really want them to understand that we don't think it's Lynch syndrome because the tumor studies are normal, but these individuals in particular have two first-degree relatives who have colon cancer, and we don't want them to ignore that or to think that they're at general population risk. We would estimate their risk is higher than average. It's just not Lynch syndrome. So the recommendations would be if you have two first-degree relatives with colon cancer, given these ages, the siblings there should have colonoscopy at 40, which means they should all have a colonoscopy now if they haven't already done so. And then these children have one first-degree relative with colon cancer diagnosed at 50, and so they would also have a first colonoscopy at 40. So again, a situation where empiric risk assessment, we did not do any genetic testing in this family because the initial test, the tumor test, came out normal. But there's still a role for risk assessment here. Yes?
Can you talk about why for Lynch syndrome there's molecular testing and for BRCA there's not? And just explain the difference between the two?
Sure.
And then also for other syndromes, is there molecular testing? So how often do we just jump to genetic testing and get blood? And then how often do we have to do genetic testing?
So right now, it's pretty unique that in Lynch syndrome, there's this screening test that we can do in tumors to look for evidence at the tumor level of basically a phenotype of the tumor that looks like Lynch syndrome. So it's been recognized for a number of years that tumors caused by Lynch syndrome will show this microsatellite instability, and that also looking at what proteins are missing from that tumor can guide genetic testing, tell us which of those 4 Lynch syndrome genes are most likely to be involved. And there just isn't a test like that for breast cancers and ovarian cancers to see if they're most likely due to a BRCA mutation. And the why of that, I'm not sure we really know the why of that actually, but it just at this point hasn't panned out. And I think people are actually looking pretty hard, like wouldn't it be great if you could take an ovarian cancer tumor in the pathology lab and stain it for BRCA1 and see if that stain is missing. And it just has not been effective as a way to identify ovarian cancers caused by BRCA mutations. So something about the biology of that tumor and the role of these tumor suppressor genes is different somehow. Or maybe such a test will exist in the future and it's just not here yet. So maybe there will be a day, maybe not that far off, where there is a pathology test that's done on ovarian cancers that tells us whether or not to pursue genetic testing. But that's really, I can't think of another hereditary cancer syndrome other than Lynch syndrome where we start with a tumor screening test right now.
We were stressing, remember the difference between germline genetics and tumor genetics, and that we're really focused on germline genetics. But the germline genetics causes a certain, what we call phenotype in the tumor. That's why even though we're focused on germline, the studies in Lynch syndrome are done on the tumor. But the tumor gives us a clue as to whether there are germline changes. But even though we're doing tumor testing, we're still reflecting that back to see if there's a germline abnormality. So that's the difference between kind of what we're talking about the last 2 days versus what you heard the first 3 days.
And this is, I believe, the last case I wanted to show you. So this is a 31-year-old woman who's never had cancer but came to see us because she's worried about her family history of cancer. Her father died young of cancer. He had melanoma and passed away at the age of 32. Her grandmother had lung cancer, diagnosed at 75, had a long history of smoking. There's a couple of relatives on her mother's side with prostate cancer, and then her grandmother with breast and ovarian cancer at 72. So she was really concerned about this family history. And we were able to reassure her. So it was news to her that most cancer is not hereditary and that cancers diagnosed at older ages are less likely to be hereditary. And it also was very helpful to recognize, so again, we've done some abbreviating over here, but it's a big family and she's got 7 maternal aunts who've never had cancer and they're in their 50s to 70s. So we might have started out a little bit worried about this, but then we saw the ages of diagnosis and the lack of this being sort of passed on in the family. So seeing that drawn out really helped her to understand and that some of the cancers in the family are more likely due to environmental risk factors as opposed to something running in the family. So she walked out reassured and having no genetic testing done. Oh, one more. So this is a case looking more like familial breast cancer. So this patient was diagnosed with breast cancer at 51. It's not a triple negative breast cancer. It's an ER-PR positive breast cancer, so really the most common type of breast cancer. She does have a family history. She has a paternal aunt diagnosed with breast cancer at 55 and a paternal first cousin diagnosed with breast cancer at 58. So no strikingly young ages, but they're not terribly old either. And it's clustering in the family, but there's unaffected relatives in between. So there's this cousin, but then her mother died at 72, never had cancer. So this is maybe more in that gray area as well. This could be hereditary breast cancer. It could be a familial clustering of breast cancer. I don't think this just happened just by chance. I think that's too much breast cancer. So would we do genetic testing here? Is there a role for BRCA1 and BRCA2 genetic testing? I think so. I think we tend to err on the side of caution there. But what we would tell this patient in pre-test counseling is you will probably test negative. But we would hate to have not done the test and you actually are positive and we miss that opportunity to provide that important information for your family. And some patients in that situation, if we tell them the risk is low, they might opt to not have the genetic test done. They might say, you know what, it sounds like that's really probably not what's going on. Unless something changes in my family history, we're just not going to do it at this point. And I think that's a perfectly reasonable decision to make here. So I don't think there's really a wrong decision here. I think we could offer her genetic testing knowing that there's a low chance we'll find anything, or we could say, you know what, this really just doesn't look like BRCA. So she ended up doing the genetic testing and it was normal, so kind of what we would have expected. And again, this is a situation where we want to come back to the family history. I do not want her to walk out the door saying, no one in my family is at increased risk for cancer because I did this genetic test and it's normal. So I would feel like I had done somebody harm if that happened. So this is a family history to pay attention to, and women in this family are probably at increased risk for breast cancer due to something else, something other than BRCA1 and BRCA2. They're probably not at increased risk for ovarian cancer. There's no ovarian cancer in this family history, and there's not really a link between breast cancer and ovarian cancer unless there's a BRCA mutation. But women in this family, because of the family history, may want to consider doing extra screening like breast MRI. They might want to consider chemo prevention of breast cancer through the use of tamoxifen, for example. And so what can be done at this point for the women in this family who have not had breast cancer, like her 3 sisters, then their risk of breast cancer can be calculated using some different models that account for this family history and also their personal history to help determine their level of risk for breast cancer and whether they should be doing extra screening with MRI or considering things like chemo prevention. Okay, so I wanted to switch gears a little bit with the last bit of time and talk a little bit about how genetic testing technologies are changing. So, historically, genetic testing is mostly done through what's now being called Sanger sequencing, so kind of standard DNA sequencing, but a lot of clinical genetic testing labs are in the process to switching over to this newer technology of next-gen sequencing or high-throughput parallel sequencing. And this new technology allows genetic testing to be done at a reduced per gene cost. So right now, the cost of BRCA1 and BRCA2 genetic testing is about $4,000. With next-gen sequencing, you can potentially look at many more genes for the same or even a lower cost than we're looking at 1 or 2 genes right now. And so there's a lot of discussion and dialogue going on about what effect is this going to have on hereditary cancer predisposition genetic testing. And I think it could facilitate more widespread genetic testing, particularly for syndromes that are rare but have high penetrance. So I'm going to show you an example of that. Given the cost per gene of a genetic test now, we have to think really carefully about risk assessment and what are the chances we're going to find something with that test, you know, for the cost-benefit ratio for that test to make sense. But if the cost of those genetic tests goes down, then maybe that ratio changes and maybe we can cast a wider net, and maybe that will end up teaching us things about these hereditary cancer syndromes that we didn't know. If we only look at high-risk people to do the genetic testing, we're never going to find out if lower-risk people could have these syndromes as well. And this is happening very rapidly. So there are commercial genetic testing laboratories that right now are selling panel genetic tests using next-gen sequencing. So this is a field that changes rapidly, and where we really have a role also in helping to assess what are the roles of these new genetic tests and what would the results mean for patients. And another area where there's a lot of research going on and where genetic testing is potentially changing is SNP or single nucleotide polymorphism based testing for common diseases such as breast cancer. So kind of using a panel of a bunch of low penetrant alleles proposed as a way to assess somebody's risk of breast cancer at the personal level. And there's been a lot of controversy about this. Some companies that do this type of genetic testing are marketing the genetic test directly to consumers, which has raised a lot of questions about regulatory issues and informed consent and privacy. And there's lots to talk about there, and probably more than we can discuss today. I think it'd be a whole other separate thing. But one of the questions that we're faced with is how do we assess a new genetic test like this and figure out if this would be helpful for a patient? So they're out there, they're commercially available. What's their role? So when we ask that question, there's a series of questions that help us to answer it. So we want to think about the quality, the validity of these genetic tests. So one question is the analytic validity of a genetic test, and that's simply how accurately does the test measure what it's supposed to be measuring. And that's usually not our concern. We're not concerned that we lack analytic validity with the genetic test. The labs, the commercial labs that do the genetic testing, are generally certified by different regulatory bodies for just basically sort of quality control and those kinds of things. Now, at the same time, there isn't any at the federal level regulatory oversight of individual genetic tests. They're not approved by the FDA. That's been recognized as a regulatory loophole, so this might be changing moving forward. But that means there isn't a kind of regulatory body that's assessing the quality of the genetic tests beyond the analytic validity just coming from the lab that's doing them, which means that we need to be kind of informed consumers, even as healthcare providers, in thinking about these genetic tests. And so the other questions that we ask about are really clinical validity and clinical utility. So you can generally define clinical validity as how consistently and accurately does the test detect or predict the outcome of interest. And clinical utility, which I think really is the most important question, and the others feed into it, is how likely is the test to significantly improve patient outcomes? What is it going to do for this family, for this patient, if we find something with this new genetic test? And other ways to phrase that clinical utility question would be, what would you do differently for the patient or for a relative based on the results? What would be offered if the result is positive? What would or wouldn't be offered if the result is negative? If our patient with whatever cancer tests positive for this gene and a relative tests negative, do we feel comfortable reassuring that relatives that we're sure that that gene, that genetic test explained this cancer and that we can reassure this other person? And a very important question, particularly for common cancers, is does that test, it's commercially available, but does it improve risk prediction compared to already existing methods? So remember, we can assess somebody's risk of breast cancer, for example, based on their family history and empiric risk assessment models. This new genetic test that's being offered, is it an improvement over what we already have? And those questions are not easy to answer, but as informed consumers, informed healthcare providers providing guidance to our patients, those are the questions we should be asking ourselves when new genetic tests come around. So one example from the next-gen sequencing world is a paper that was recently published, and subsequent to this, now commercial genetic testing laboratories are offering a test parallel to what was studied in this paper that looked simultaneously for mutations in many genes in patients with ovarian or fallopian tube or primary peritoneal cancer. And this is what this paper found. So they were doing BRCA1 and BRCA2 genetic testing, of course, and found kind of the expected number. So again, there's that 17.5%. So in this ovarian cancer population, then 17.5% of them have a BRCA mutation. So reminding us that that's really common. And they looked at 19 other potential tumor suppressor genes that have been hypothesized to potentially be responsible for hereditary ovarian cancer. And they found 19 other not BRCA1 or BRCA2 mutations in 10 other genes. And you can see what those are here. So one of them is P53. So this, I think, was one of the most interesting things about this paper. So again, you've already heard about P53 mutations in Li-Fraumeni syndrome. This is a pretty rare syndrome. And it's not something that we classically think about with ovarian cancer. And then here's this research study that cast a wider net, that used this new genetic testing technology to cast a wider net, and found that not a huge number, but 3 of these patients had P53 mutations. And some of them had no family history, which brings us right back to de novo mutations. And for at least a couple of these patients, they believe that it is a de novo mutation. So that's very interesting. So if next-gen sequencing would allow us to be, there's not a way for me, based on a family history, to pick out an ovarian cancer patient and say, you should have P53 genetic testing, unless there's a strong family history of the cancers you've heard about, sarcomas and brain tumors. These patients didn't have that strong family history. In doing classic DNA sequencing gene by gene, it's not really feasible for every ovarian cancer patient to have P53 testing. The BRCA, given that high likelihood, that seems very feasible. But if we're doing next-gen sequencing, the cost goes down. Maybe this means that P53 genetic testing moving forward would be done more commonly. Maybe it's not just ovarian cancer. And maybe we're going to learn a lot of things about this Li-Fraumeni syndrome that we didn't know before. So that's one interesting, I think, very tangible thing that came out of this paper. And then there's this. So the other mutations that they found, these are genes that there's research to suggest that they could be involved in tumor suppressor pathways, but there's not a body of literature telling us what your cancer risk is if you have a mutation in one of these other genes. CHEK2, there's lots of controversy. That's a whole other discussion. MSH6, of course, is Lynch syndrome. So that's another thing that we know about. And there is an increased risk of ovarian cancer in women who have Lynch syndrome. But you know, we have no idea really what it means for an individual patient. There's lots of interesting research, but from the clinical side, we do not know what it means if a patient has a mutation in the NBN gene. So I think it's a little bit of a mixed bag at this point, these panel genetic tests. If I could pick out my own panel of genes that have known implications and I could order that on patients, I think that would be great. But a panel that includes these genes where there's no known implications for the patient at this time, I think there's a lot to think about there. And this is very new. These tests just started being offered. And so our feeling at this point is we want to pause, see what the research is telling us, and not necessarily jump into something where it's not clear this is going to be benefit to our patients. But we're very excited about where this may be going and what kind of benefit this might provide. It's a real paradigm shift and a very exciting one. And then, how am I doing? Just in a couple minutes to talk about SNP-based testing for common disease risk. So this is sort of a whole other ball of wax, a different type of, it's an area where there's lots of very interesting research being done and a lot that's being learned about common diseases through this type of research. And then there's commercial genetic testing labs that have decided to start offering tests, sometimes direct to the consumer based on that information, and many people would say probably prematurely, that we have a lot left to learn. So for common diseases, and this is just a quote from someone who's thought a lot about this and I thought was well put, we have a lot still to learn about common diseases and what the genetics of them are. And we've learned from genome-wide association studies about some risk alleles, but there's a lot out there that we do not yet know. And so his argument that at this point is trying to predict who will get the disease based on that limited risk information would be akin to flipping one coin and using the result to predict how 19 other coins would land if they were flipped. So let's say there's 20 alleles that determine your risk of type 2 diabetes, for example, a common disease that clusters in families, and we don't really understand the genetic basis of it. We understand about 5% of the genetic basis of that clustering. So if we did a genetic test based on that 5% that we understand, we're learning the result of one of those 20 coin flips. But we don't know the results of those other 19 coin flips because we don't even know the genes that are causing that. So can you predict risk based on knowing the result of that one coin flip? And I think no. I think we need to learn more before this type of genetic testing approach is going to be clinically useful, is going to make it better than assessing based on family history. It's exciting research, and there's lots to be learned from it, and it'll be very interesting to see where this goes moving forward. And this is an ongoing dialogue. So this is a paper that was just published in the Journal of Clinical Oncology. And I didn't want to discuss the details, but just kind of show you that this is an ongoing dialogue. So it's a research group that's proposing that there is a panel of SNPs that they looked at in patients who had familial breast cancer. They had that clustering of breast cancer in the family, but didn't have a BRCA mutation, and trying to see how that could be used to refine risk assessment in that family. And then with that was published an editorial that's asking those questions about clinical utility. So the remaining questions at this point are, does it improve on current risk assessment with models such as these are the models that we can use to assess risk based on family history? Otherwise, showing modest modulations in still high-risk clinical situations will not change clinical decision-making nor influence potential interventions. So that's that gold standard question of what are you going to do differently for this patient or their family members based on the results. Risk assessment by genome-wide association studies, such as this study in a high-risk population, will need to outperform the current free, readily available risk assessment models that are now being used in clinical practice. They're encouraging and hypothesis inducing and hopefully have promise for the future. So I'm not claiming to know the answer to the question of where this is going, but just wanted to give you a feel that this is a very dynamic field. This stuff was literally just published, and there's a dialogue and a lot changing and a lot moving in the realm of genetic testing, and so many exciting things yet to learn. So thank you very much for your attention. I'm happy to take questions.